think we can go ahead and at least I will get started with the introduction. So let's go ahead and do that. So welcome, Hans-Peter. I'm just going to give a little bit of background. Dr. Kohler is the F.J. Warren Professor of Demography and co-director of the Population Aging and Research Center at Penn. He got his PhD in economics from UC Berkeley, and he's been the director of the Malawi Longitudinal Study of Families and Health since 2007. He is widely published on topics related to global aging, life course perspectives on health, fertility, social and sexual networks, HIV/AIDS, and biodemography. And his work has had substantial influence on policy and media discussions related to demographic change. He's been awarded the Clifford C. Clogg Award for Early Career Achievement by the Population Association of America for his interdisciplinary work on fertility and health. And he's been honored with Otis Dudley Duncan Award, the Otis Dudley Duncan Award for Outstanding Scholarship in Social Demography by the American Sociological Association. And he gets funding from NIH, NSF, among other institutions. And today he's going to tell us about the work that they're doing in Malawi, which is not yet based on genetics, but maybe in the future. And to just have a discussion about that and maybe even initiate some collaborations amongst people on this Zoom call right now. So with that, I will let you take it from here, Hans-Peter.
No, thank you very much. I'm delighted for the opportunity to talk to you. And you set the tone. I mean, I think we've been aware of, your work, and we've tiptoed a little bit into genetics in various ways. But the idea of this discussion is to kind of show what we've been doing, what kind of some big questions we find interesting, and then at the very end, see where there might be possibilities to collaborate in the area of genetics and epigenetics, because we think there might be a real opportunity to move some of these things along. So let me get started. So broadly, the idea is going to be, connecting these big themes: demography, aging, and global health. And as Sarah pointed out, this draws on our work in Malawi based on the Malawi Longitudinal Study of Family and Health. And while I'll do the talking, at least initially and for the most part, I want to give credit to a large team at Penn in Malawi, both on the implementation side as well as academic partnerships, and then a very large research team that's ultimately spread out across the globe that has various contributions. So anyway, this is a really collaborative project, and what characterizes this project also is our commitment to share data. So we make data publicly available and argue that this is, this over the years has become a real resource that we both want to expand and continue, but we don't want to keep for ourselves. We want to kind of get people connected to this, because in some ways we say, if you're interested in sub-Saharan Africa, if you're interested in studying very poor individuals at various stages of the life course, this is going to be a really interesting resource. So the specific study goes back to my PhD times. I was still at Berkeley when I got connected to this. And the history of this project is in ultimately trying to understand fertility and social networks. And credit goes to Susan Watkins, Jerry Behrman, and others who in 1997, 98 set off a project with many very sensible study designs, drawing a real population sample in 3 areas of Malawi, in Rumpi in the north, Mijinji in the center, and Balake in the south, enrolling at the time about 2,500, 3,000 individuals, and creating a team that was committed to this project and has been able to keep the project alive and change its topic and move forward. So over the last 25 years or so, we've been going back and collect survey data, biomarker data, conduct some randomized experiments, and now I have created this 25 years of cohort data going back to these individual original respondents, but we've added siblings, we've added children thereof, we've added spouses. So we have this group of 4,000, probably too little, 6,000, 7,000 individuals at the moment, about whom we have a tremendous amount of information about the socioeconomic context, their health, their social networks, obviously aspects related to HIV, non-communicable diseases, and many other aspects. The core of this is the survey data that we've been collecting over many years, but there's some complementary qualitative data. There's lots of contextual data. We link infrastructure data and other aspects. So in some ways, this has emerged into a really nice, unique data set that has this large cohort data combining social, economic, demographic information and contextual data. But then, credit goes to Iliana, who is on this call a few years ago. She pointed out that you've been focusing on questions affecting young individuals, midlife individuals, but your respondents are getting older. And the older set of respondents might actually be quite old. Why don't you start looking at a set of questions related to aging, NCDs, cognition, mental health, some of these other aspects? So starting in 2012, we kind of augmented our ongoing research interests with kind of study questions related to aging. And today I want to talk primarily about these aspects. So what's interesting about aging in places like Malawi? So here we study aging in lots of places, and all the dots you see on this graph are basically prominent population aging studies. In the US, this would be the health and retirement study, lots of globally international studies, and so forth. The horizontal axis, you have the Human Development Index. So to the right, fairly rich developed countries, to the left, relatively less developed countries, to the very left, quite poor countries. And on the vertical line, you have the growth rate of the older population. And the upshot of this graph is that we study aging extensively in very developed contexts where the growth rate of the older population actually isn't all that fast, so about 1%, 2%, but population aging is characteristic. But anyway, on this kind of top right corner, we have lots of data sets studying what happens in terms of health, social context, whatever you're interested in to older people. But most of these studies are restricted to individuals living in fairly affluent context. Then there's been a growth in studies in kind of middle-income countries, in Mexico, kind of South Africa, big studies, like kind of SAGE studies in India, Ghana, China has some of them. So there's been a growth here. But what is interesting here is that we truly have no population-based data sets that allow us to look at processes of aging, both in terms of measuring health and disease at older ages, on studying social relationships, intergenerational transfers, but also life courses in relatively poor contexts, such as Malawi here. And you might initially argue, well, it doesn't matter because aging actually is not a dominant issue. And by some measure, that is correct. If you define aging as population aging, so this fundamental transformation of the age structure that occurs at the end of the demographic transition, places like Malawi don't yet have strong population aging for decades to come. Age distribution in Malawi is going to remain with 50% of the population below age 18, 19 for decades to come. But the growth rate of the older population is very rapid. It's much more rapid than in any high-income context, and arguably, older individuals are the most rapidly growing subset of the population in these countries. So in Malawi, that's about 4%. That would mean a doubling of the older population every 20 years or so. So there's a very distinctive aging concern, which is not population aging, but this rapidly growing number of older individuals about whom we know very, very little. We really don't have studies at the left end of this graph to study aging in these contexts. And there are probably strong reasons to believe that low-income countries such as Malawi, aging in its health perspective and its social perspectives is going to be different from what we can observe in high-income countries and middle-income countries. So we can't just extrapolate what we observe in these data dots that we have here and think, well, maybe it's going to look very similar in low-income countries. We're going to argue, and I hope to show some evidence that this is wrong. If you're interested in how aging unfolds in this, to the left of this graph with this rapidly growing number of individuals of older people, you need to go out and study these individuals and collect aging data sets and do this in interesting ways. So here,
Hans-Peter, can I just ask a question?
Yeah.
And maybe you're going to go into this, but should I assume that the reason that you have this rapid growth in the in the aged,
Mhm.
I don't know how you say it,
Yeah.
is because, would it be because the starting like life expectancy in many of these communities was very low? And is it increasing now because of better healthcare, or, are you, I don't know if that's something you're going to get into.
Basically all of the above. So on one hand, the current individuals are basically, the initial set of individuals, infant mortality, early life expectancy went down. So it's basically individuals who were born when global population growth became a major issue. Then there have been, ongoing declines in mortality disrupted by the HIV epidemic, but then more recently, big first increases, but more recently big declines in adult mortality because ART helped to turn HIV into much more manageable disease, and less pronounced, but gradually also improvements in health at older ages. So I think the primary factor is just historic population growth. That's at the root thereof. And then on top thereof, there is a whole set of other factors, such as improvements in mortality across the life course, recent improvements in mortality due to antiretroviral treatments, reduction of AIDS mortality, and so forth.
Okay, thank you.
So, here, as in Malawi as well as in many other places, as individuals get older, there are major divergences. So, to the left, you have arguably somebody who has healthy aging, seems to be mobile, possibly productive, rides around in his bike. And to the right, you have somebody who, at least based on superficial inspection here, deals with mental health issues, certainly much less healthy aging trajectory. So there are important divergences in aging trajectories. And, to kind of drive home that point that how distinctive these low-income contracts is here a graph of kind of GDP per capita, so income per capita of kind of the 50 globally poorest countries. So here to the left, you have a set of 50 countries that, were all relatively poor in the 1950s, and Malawi was among them. Malawi was a poor country in the 1950s, and it is a poor country today. But then you see that, many countries that were relatively poor in the 1950s had, development, a subset of them striking development. So this graph is on a logarithmic scale. So there's a tremendous 40-fold variation in the y-axis. And there's the Mexicos, Koreas, Chinas of the world who kind of had very, very rapid development, and subset of countries who had more moderate development but significant development. And then low-income countries like Malawi stand out that basically over many decades, there has not been a fundamental change in income levels. So the individuals that are now old basically survive through a life course of poverty, adversity, and so forth, which is very distinct from the type of patterns we study in middle-income countries, where the current older individuals might have been born when the countries were relatively poor, but then across adult lives often experience fairly rapid development in much better socioeconomic context. In Malawi, we study a set of individuals who through most of their life basically lived on roughly $1 a day, and arguably kind of how life unfolds both in health dimensions, social dimensions, anything you might care about. Is going to be very different if life is spent in a context as is illustrated in this red line, as compared to a set of contexts that reflect to other countries that experience significant development. Just kind of two more pictures of some study context. This is what our study areas look like. The right would be in the north, Rumphi, and I think this is from the southern area. And just to kind of provide a bit more context as well. So when these individuals were born, infant mortality was really high. So this is a kind of histogram of observed under 5 mortality based on the UN population prospects up to about the 1970s. And, there was a lot of variation in under 5 mortality prior to the 1970s, between 1950 and 1970s. But, Malawi in 1950 to 55 still had, strikingly high infant under 5 mortality. So more than a third or so of individuals actually died in the first 5 years of life. So what we're also studying with the current older people are a set of individuals who were, very selected. They faced very high infant mortality. They faced, fairly high mortality throughout the adult life course, and all of that may affect how life unfolds at older ages. And then obviously the world has changed, and with infant mortality has changed, very dramatically. That may also affect how younger generations age as they get older. We alluded to this before, kind of what is interesting in many sub-Saharan African contexts affected by the HIV epidemic, that there was also a major adult mortality shock. So what you see here is 5-year survival probabilities at ages 35, 45, and 55, kind of during the 1990s and 2000s. And what you see here is, as a result of the HIV epidemic, initially, significant drops in the survival probability in kind of primary adult ages. And then, in the last 2 decades, important reversals. And arguably, this had big imprints on individuals' lives as well. If we study older individuals at the moment, we look at the survivors of these mortality shocks that, again, didn't affect young people, but primary adult individuals. So arguably what one can study by looking at older individuals in places like sub-Saharan Africa is that this is a really remarkable cohort. It's on one hand the survivors of the AIDS epidemic, but it's the survivors of, adversity throughout the life course, that fairly high adversity early in life, as we've seen, as illustrated in under 5 mortality, but it didn't stop. It occurred throughout the life course. We have poverty, famine, lots of other crises, lots of other aspects. And, on top of this, layered the AIDS epidemic, more recently, COVID-19. And so, a couple of questions. On one hand, one could argue, how did these individuals actually manage to become old? What are the kind of individual strategies, community strategies, family strategies that make it more likely that you actually survive in these contexts? And conditional on survival, how does the fact that, life was a struggle to some extent, how does that affect kind of health and aging going forward? And, in this context of, global aging studies, there are these really interesting questions we want to come back to. How do these life courses that were characterized by, remarkable adversity affect health and aging at older ages? And so let me just kind of illustrate some aspects of what is interesting. And this is just another summary slide that we're going to look at the MLSFH data here. So one interesting domain is mental health. So it turns out that in high-income countries, broadly speaking, mental health actually improves as individuals get older. Happiness goes up, mental health goes up, depression goes down on average. If you look at individuals in Malawi, we find the contrary. So what we see here is kind of a depression score, PHQ-9 depression score for individuals above age 45. And on one hand, you see kind of a striking gender difference, so women being more depressed than men, which is interesting to begin with, because that's a kind of reversal of gender patterns that we observe in many high-income contexts. But then also different from what we observe in many higher income contexts. Kind of depression goes up and anxiety goes up, and other measures of mental health go down as individuals get older. So one sign that kind of aging is challenging, and it's not necessarily, healthy aging, happy aging. Depression goes up, mental health declines in these, and that's quite striking. Then, because we have longitudinal data, right, what we can do is measure transitions into, depression and out of depression, or into physical disability and out of disability. And, it's kind of clear that there are transitions in and out. If you're depressed, you may recover, and then you may re-enter depression. The same thing for physical ailments. And so with data along the lines that we have, we can look at these transitions and then compute life expectancies. So after age 45, how much of your life do you spend with depression, with functional limitations or other aspects? And so this is here a graph that shows these type of healthy life expectancies or unhealthy life expectancies at various ages above age 45. So this is age 45, 55, 65, 75. Kind of the width or the area of these bars is proportional to remaining life expectancy. At age 45, that would be about 28 years, and at age 75 would be about 9 years. And then you see that individuals spend at older ages a striking amount of their life course with, in this case, depression. And we have similar analysis also for kind of physical disabilities that, after age 65, 40%, and at higher ages, more than 50% of life are spent, in this case, with depression or poor physical health. So again, the sign here is that getting old is really challenging, and there is what we have called this accelerated aging. So an earlier onset of disabilities or poor mental health, more rapid decline of health, and it affects both many individuals, but it also affects a very, very remarkable or perhaps striking kind of fraction of an individual's remaining life, at not so old ages.
Hans-Peter,
Yeah.
I have a question.
Yeah.
So the method that you use for determining anxiety and depression, I'm sorry if I missed this, but is that based on a European test, or is it modified for that population? Could there be cultural differences that could impact that? And also, did you see any differences between people living in a more rural area versus an urban area?
Yeah. So, lots and lots of good questions. The elephant is in the room for, as you're well aware, there is the aspiration to have harmonized measures. We often draw on batteries that are developed in high income contexts, and you aspire to having comparable data. So you often start with measuring with, instruments, survey measures that are developed for these contexts. And, we do the same thing. We start building on these, but then we, try to do validation, careful tests, and all of these things of these measures. But I don't need to tell you, you're very much familiar with this. This is very challenging, and for sure, for instance, sensitization to poor mental health is much less prevalent in places like Malawi. And so here with give you the story about mental health. So this mental health score is kind of 9 questions on kind of in the last 2 weeks, have you felt depressed? And I forgot, Iliana might be able to have the questions. I'm blanking on the moment, but a set of 9 questions about, related to depression in the last 2 weeks. And if you look at these Western scales, down here you see that, 1 through 4 would be minimal depression, 5 to 9 mild depression, and then moderate depression, and then, above a score above age 20 would be severe depression. And it turns out that we decided in our study that these kind of Western cutoff points for categorizing people in these depression categories are not all that useful, because people are undersensitized, perhaps underreport this. So we get very few people who would be, mildly depressed or moderately depressed by these cutoff points. But, this being said, we believe that this kind of continuous measure of the score, it actually picks up, important variation in depression. And you can see that people who score higher on these things kind of eat less, they have less sexual intercourse, they have less subjective well-being. So there's lots and lots of evidence that we're picking up real variation in depression, while at the same time, I'm happy to admit that these kind of classic cutoff points by which we classify people into different depression categories, you simply cannot apply at this. And
then now that you pointed out, it's actually interesting that the highest you go there is below 8. And so overall, if you use the European score, they would not be considered as very depressed compared to Americans, I would imagine, right?
And that's, these are averages, but I think you're absolutely right. So these are kind of standard errors, not box plots nor kind of interquartile ranges. But that is correct. And that continues to what I want to do. Wanted to talk next. So we've also become very interested in cognition, and not surprisingly, if for anything that we care about, any human activity and so forth, the brain is going to be central. So brain health is key to understanding anything individuals do, and variation in brain health is important. And we know that as individuals get older, that's one dimension that possibly changes very rapidly as a result of ADHD and a bunch of other factors. And so we, and credit goes to Ileana here, we kind of developed a kind of instrument that allows us to measure, cognition, cognitive function in kind of key domains. And, we can look at how cognitive function is measured in population studies. They're even more recently kind of harmonized HCAP, harmonized cognitive aging protocol. And, you want to measure cognition in these different domains, such as, orientation and immediate delayed episodic memory, recognition memory, visual spatial aspects, executive functioning, and so forth. And in some ways, we did the same thing as we did for depression. You start with an established instrument, but then you realize very quickly that older individuals here, 30 to 50% didn't attend school, are illiterate, they may not be able to hold a pen. So there are lots and lots of kind of adjustments you need to make in order to make it feasible to implement these scales in the context we're studying. And, and the approach is presumably what you, what you think. You begin with established instruments because you aspire to some comparability, and then do, very careful focus groups, pre-tests, all of these things to develop it. And then you need to assess and see, whether these things work and behave the way you're supposed to work. So it's these, trade-offs that you need to make, or these balancing acts that you need to make. And, and admittedly, we and other studies trying to do this are really pushing the frontier, because they're not these templates out there of aging studies in low-income countries where you could simply take something and that works. We are among the first studies trying to do this, and part of it is trying to figure it out, and that has for sure some trial and error component. But on the other hand, because this is a study run by us with often reasonably good funding, we have the motivation and effort to try to do our best to get these things right, which I think if you kind of outsource data collection to just major survey companies and give them a contract to collect some data and then wait for the data to show up on your computer, incentives might be very different and data quality might be very different. So anyway, we invest a lot of effort in developing these measures, scales, pre-testing them, developing training, developing a team that can implement them, and so forth. And so so we have this kind of cognition scale. That's like the MOCA instrument. As our previous president pointed out, if you score 30 on this instrument, your cognitive function is very high, and below you have less cognitive function. If you go quite below, you might be sign of cognitive decline, dementia, and so forth. And so what you see in this box plot on the left is, the distribution of cognition among individuals 45 to 55 years old. On the left box plots here, when we were first measured this in 2012, and then in the adjacent box plot next to this, 5 years later in 2017. And so, you see there's a fair amount of variation in cognition, as you would expect across individuals, and there's gender differences, very marked gender differences, as we'll see, and some SES differences and other stuff. And then, among relatively young old people, 45 to 55 years old. If you test them a few years later, yeah, there's a little bit of a decline, but it isn't all that pronounced yet. But once you look at older individuals, you see on one hand a kind of cross-sectional decline in cognitive function as individuals get older. So older individuals are performing less well on these cognitive tests, and quite substantially less well. But if you look here at individuals 75 plus, if you test them here at 75 and then 5 years later at age 80, you see significant decline. So there is this, rapid decline in cognitive function that occurs at not so old ages. And on the right-hand side, you basically just see the same thing. We kind of fitted some age period cohort model to this. Kind of highlights here that the gender pattern that I pointed out before, women having much worse cognition than men, and at older ages, kind of cognitive decline accelerates. And, arguably cognitive decline begins at, kind of early old ages, so much earlier, arguably, as you would expect it to see in higher income contexts. Related story about physical health, or dimensions of physical health. And here is kind of hypertension, which is also interesting. Cardiovascular disease is a leading cause of death. It has a big burden of disease here. And here you see kind of these hypertension patterns, again, above age, for individuals above age 45. Box plots the kind of actual distribution of systolic blood pressure. And what is striking here is that this is a population that hasn't yet a lot of exposure to Western diets. As we'll see in a second, the body mass index is relatively low. If anything, the concern is undernutrition rather than overnutrition. And their blood pressure is high, by some measures, strikingly high. So, if you look at individuals 65 and older, 75% of the study population is pre-hypertensive. And at older ages, 50% are hypertensive. So there are these kind of strikingly high hypertension levels that goes up as individuals get older, but doesn't occur because of the kind of standard explanations that are often brought forward. It's not because of a lack of physical activity. The right-hand side, you have body mass index. So body mass index is fairly low, and it's certainly not going up with older ages. It's not driven by an obesity epidemic. So there is something else is driving high blood pressure, and probably related to the type of life course experience these individuals had. Kind of a quick point here. Then, if you face kind of these health patterns that we have here, the obvious question is, can we do something about this? And here are kind of findings of kind of health screening intervention. So here, as part of our survey, we tested individuals for their blood pressure, and then individuals who had relatively high blood pressure kind of got a note that indicated that they should see a doctor because they have hypertension, or kind of potentially hypertension. And then 4 years later, we measured what happened to them. And then it turns out that despite the fact that the healthcare system is relatively poor, we provided them ultimately very limited information. There kind of declines in blood pressure, declines in hypertension, an increase in diagnosis and medications, and kind of improvements in subjective well-being. So indicating here that if we're concerned about the health of the elderly, sometimes they're cost-effective, relatively simple interventions, in this case, a screening intervention, that can make a real difference in the outcomes that we're interested in.
Can I ask you, what is RDD?
RDD is regression discontinuity. So these were attempts to estimate causal effects of the screening intervention on the outcomes we're interested in, and we pursued two analyses: a regression discontinuity approach, where we looked at individuals who were just below, they got this referral letter just above, compared the difference, and then matching approaches is another way of matching individuals based on similar observable characteristics to identify causal effects. Yeah, I slipped over this. So these are kind of the two approaches to get causal effects. And before I want to give an outlook a little bit of where stuff is interesting. So I want to kind of talk for a few minutes about early life influences. So I alluded to this before. One of the hypotheses that we have about health at older ages is that significant part is influenced by life, by early life, kind of in uterus conditions, early life conditions. And there's this long shadow, or arguably this long shadow of early life conditions of growing up in poverty, being exposed to in utero shocks, and so forth. And the individuals we study here get a fair number of shocks, including in early life, and many of these shocks are related to weather conditions, famines, and so forth. And this is not the famine we study, but this is one that was popularized, including by a book and by a Netflix movie. This one occurred, I believe, in the 1990s. The one that we studied occurred in 1949, Nyasaland famine, a well-documented famine while Malawi was still British colony. Basically, rain stopped in 1949, wiped out the harvest in 1950, and then produced these kind of almost 2 years of kind of hunger years of severe shortage of food as a result of the 1949-1950 harvest being wiped out. And the prediction here would be that individuals exposed to this early life shock actually have worse health at older ages. But we looked at multiple domains here. Here you see kind of blood pressure. Here you see changes in blood pressure. We look at some other outcomes. It turns out that individuals who were exposed to this famine actually have lower blood pressure. They have less increases in blood pressure as they get older. There's a bunch of other outcomes. They have less diabetes risk. They have fewer number of stroke symptoms. So here there's a kind of pattern that individuals who were exposed to this Nyasaland famine some 70 years later have slightly or have somewhat better health, and in none of the domains we studied actually worse health. And so this is really interesting because it kind of questions, these implications of these Barker hypothesis or the, developmental hypothesis of later life health that puts this strong emphasis on the adverse effects on early life shocks. But we've studied this mostly in contexts where individuals had early life shocks and spent most of their adult life in, significantly better context and more rapidly developed context, sometimes very much more developed context. And here we show that, these kind of consequences of early life adversity might be very different if you study individuals who faced adversity in early life, in utero, in this case. But then it was followed by basically a life course of adversity related to just poverty and additional famines, lots of other shocks as well. And it could be here that for these populations, kind of an early life shock may have prepared the body or the cardiovascular system for lifelong adversity. And across multiple patterns here turns out to translate into better health at older ages. And it's not, we argue this is not due to mortality selection. So we looked at this in a fair amount of detail. It doesn't seem to be that these cohorts were just simply more selected in terms of mortality. If anything, they seem to have had slightly lower mortality. So let me kind of stop here. We did some COVID research and so forth. So what I wanted to kind of show here is that, studying aging in these contexts is arguably really interesting. We can simply take what we know from studying in higher income contexts and say, yeah, these things are going to translate to these contexts. Aging may be very different. It occurs at younger ages, may occur much more rapidly, may have very different risk factors, patterns may be different, and that's just the biological aspect, the health aspect. The social aspects of aging might be really different as well. And there's real potential to study. And now I wanted to kind of spend, the last few minutes kind of opening up and then invite Lauren Schmitz, who is on, and, Ileana to join a little bit more, which is related to the discussion we're having. So the selling point, I said, is, we really want to study aging. There's something to be really learned by looking at getting older in these study populations and studying a set of health and social outcomes in this context, but including prominently cognition, ADHD, and these aspects. But then what is really cool here is that we can build on these kind of 25 years of cohort data. And then, additionally now kind of use epigenetic progress in epigenetics and genetics to actually try to measure aging. So to calculate biological age and kind of measure pace of aging and differences in biological age in among individuals to, on one hand, kind of study how a set of factors, kind of social factors that are at the above here, anything from individual behaviors to schooling, to interpersonal relationships, to shocks such as food crisis, affect epigenetic aging, whether individuals age faster or slower, depending on the type of adversity that they experience from early life throughout midlife to older ages. And we can see whether any of these influences that occur above kind of interact with genetic or biological processes of, biological resilience, whether they affect aging. And so, we argue that we can do these things, and we not only want to do that in high-income contexts, we want to do this with study populations the way we have to approach this epigenetic and genetic aging research to study aging. And then, and then study aging and biological measures of aging, such as epigenetic age. And then also look at how does variation in epigenetic age then affect outcomes we care about, such as cognition, cognitive decline, and so forth. And so, the discussion that, we had, and you're familiar with, Sarah, is we're kind of working on, grant proposal that would go out if it gets funded to collect both genetic and epigenetics for about 3,500 individuals above age 45, combine these epigenetic and genetic markers with, both life course data. We know what happened to the individuals before they got old, and then layer on top of this a set of really interesting health and social measures of what happens when individuals are old and as they get older, with kind of cognition, ADHD, but physical health all being kind of key outcomes, to then argue that we can study biosocial aging in a really interesting context, and going to learn something that is arguably a big contribution to our understanding of aging, because this is a population that has plenty of adversity throughout the life course. And anyway, aging is likely to be different, and these kind of abilities to do this with genetic and epigenetic provide us a completely new lens of kind of incorporating the life course and look at aging. And now I kind of stop here and, see whether Lauren, show yourself, whether you have something to add, and then Ileana as well.
Great, thank you so much. I guess do you want them to start the discussion?
Why don't I see whether Lauren and Ileana have something to add, if they're here?
Yeah, no, thank you, Hans-Peter. That was a great summary of everything. And yeah, I think we're excited about potentially being able to measure epigenetic aging in this population. There just aren't a lot of studies in low-income countries that have used epigenetic aging measures, and most of them have been trained in high-income country samples. So both to see if those epigenetic aging measures work in this population, and then also train new epigenetic aging measures based on this population. So yeah, the prospect of incorporating epigenetic data into MLSFH, I think it's really exciting. But happy to answer any questions.
Mm-hmm.
Yeah, I think, Hans-Peter, you provided a very, very good overview of the project and what we've done in the past and where we are going. So I don't have anything else to add at the moment. So I'm also happy to take questions.
So, Sarah, and that's, I think, the opening point too, where I think, we have kind of existing data, but we also have an infrastructure in place on, running population surveys and to make, we haven't done it yet, but I think we've done some of the groundwork. We're confident that we can collect genetic and epigenetic data in, get all the required approvals, and anyway, we can make it. We're confident we can make it happen because we have a long history and strong ties. And so there is, on one hand, these kind of specific idea that we're proposing, but the kind of broader question is, if this looks interesting to you and others,
Yeah, well, why don't we
else?
open it up for discussion? And if anybody has any thoughts or comments or suggestions about genetic and epigenetic studies or markers that could be looked at, I certainly, I can get us started. I do think that looking at whether the epigenetic measures of aging are similar or not, or can be calibrated the same way, is important, because we just have absolutely no idea. Everything's been done based on mainly looking at people of European ancestry. And I am wondering, given the severe adversity that you pointed out that people face, the much older people, right? And they had very severe adversity. And then it kind of just, definitely dropped as the years went on. Could you consider actually looking at any broad genetic differences between the young and the old, or sort of like maybe 20s and the really old, to see, because they had something to survive. So they might have had some genetic variants that allowed them to survive to that age. Would be kind of cool.
So, and we don't have it on the agenda for this, both because I got to sample. Anyway, every grant needs to have a focus on this, but in some ways you're correct, and I think it's a sample size question on kind of how much sample size would you need across the life course. But my idea would exactly be, so we kind of have this idea about the 45 plus population, but our study population has a significant number of individuals at younger ages. And so you're basically anticipating the next step. If we get this off the ground, then my immediate sense would be, okay, we do exactly what you do, look at genetic cohort differences in, kind of distributions of various alleles across cohorts, but fill in the bottom of that.
Yeah, I'm just thinking of, they've done this for malaria related research, right? Where they actually look at the variation in very young children, like, even pre-age 5, and then look at the ones who actually made it to adulthood. And sometimes looking at candidate genes of interest to see if there's differences. So Getnet, you have your hand up.
Thanks so much, Dr. Kohler. That was an awesome presentation, you and the team. A couple of points. Number one is I'm aware in Africa there is what they call the INDEBS network of different DHSS sites that collects similar kind of longitudinal data. I'm just curious if you're also part of, I know in Malawi, Karonga or some site was part of the INDEBS. Not too sure about the other side. So
we connected to them and have good relations with the in-depth network. The in-depth network has some specific, kind of complicated story. They have specific eligibility criteria of kind of have basically an ongoing surveillance site, which we don't have. We follow a cohort, but we don't have a community surveillance site. And in part, on the positive side, this population is much more dispersed than what you have in these kind of demographic surveillance sites. It's still, somewhat regionally concentrated, but it's more dispersed than these surveillance sites. So anyway, the upshot is we're familiar with them, we collaborate with them and have close ties. In some formal sense, we're not a member of the in-depth network. But the in-depth network has done much, much less in the areas where we think we are strong. They've been very good in collecting demographic surveillance measures, fertility, mortality, other things, and produce interested in fertility mortality across African countries,
Yeah.
that's the go-to data for you to have. What they've done much less is these kind of extensive life course data documenting the social context of individuals, of measuring health and both the kind of socioeconomic determinants of health and health outcomes themselves, including in domains we're interested in, such as NCDs or cognition. So I think
that's great. Yeah. I mean, a couple of additional points. Number one is, I mean, you started with how good your data sharing platform and policy is, and perhaps, yeah, we may want to hear more about the data sharing principles, because in most LMICs, that's one of the issues that we usually face whenever we want to partner. So want to hear more about that one. The other quick question is, while looking into early life adversaries and all those issues, I'm just curious, Malawi being one of the countries that was heavily affected by HIV and other diseases as well, and since it has been some time since the antiretroviral drug provision and all that has been started, same as early life adversaries and others you looked into, I'm just curious on the long-term effect of the heart, the antiretroviral drugs if that has been looked into, especially in your PROS publication, if that has been
So we haven't done that yet, but so in short, we haven't done that yet. But in anything you're going to do about aging, that would be one of the aspects you want to look at. We know, because we've tested individuals, when they got tested. Anyway, so we can do it. It would be on the horizon. I don't have any specific study at this point to rate to, but it's obviously, it's layered throughout this, that there is aging and there's aging with HIV, and there are two components to this. This is the aging of individuals who are HIV positive, and then kind of the broader aspects of aging of families where individuals are HIV positive, which is different from that.
And I see.
But let's follow. Just sorry. Reach out to me. I'd like to follow up on both kind of data sharing on the issues we raised. I'd be keen to have a follow-up discussion. So just let's reach out and connect.
And by the way, I should introduce Dr. Yamir is actually new to PEN, just actually physically here for the first time today, and is also part of the Center for Global Genomics and Health Equity, Assistant Director of Global Research, I think is what we said. So again, thank you for your insight.
Wonderful. So then we should follow up with having a coffee and discuss it in person.
We should definitely connect.
And he has extensive experience, global health experience. So I see a hand raised by Kandwani. I hope I'm saying that right.
Yes. You're muted. Yeah.
Oh, I was muted. No, very, very interesting data. And I was wondering, and Hans-Peter, you mentioned about the Berker's hypothesis. Do you think, and you really commented on the effect of all those circumstances and now old age and linking it to cardiovascular health, which is very interesting. And one of the interesting interactions that we know is the environment. So we can't just look at the circumstances and then and forget about the environment. And of note, you really described how this population, which is aged, most of them have got a very good BMI below the cutoff, which we know. Do you think that missing link for those maybe people who have migrated out of the rural areas where most of this research is happening, for those who have migrated maybe to town, have a different story than these people who are there? Or in your sample, did you have a comparison about for those people who moved or to a place where there's more urbanization, etc., and who would have a total different story from this? Thank you.
So the study population we have is rural in origin, and we follow them up into urban areas, but our urban sample, a truly urban sample, is relatively small. So in some ways we have nowhere the power to kind of address the specific issue at the moment, and expanding the urban sample is something we can discuss and should discuss at some point. So the interaction with urban migration we cannot do. We have ultimately too few people who go to truly urban areas, much more kind of peri-urban areas. We looked at a whole set of other interactions, gender, education, schooling, and so forth. So for these early life influences, there's some weak evidence that some of it is mediated through schooling enrollment. And we kind of, if I recall correctly, we documented kind of some findings, somewhat, weak and caution it because I think they're somewhat at the weaker end. But anyway, some plausible mechanism through schooling, but we didn't find particularly strong interaction. So in some ways, I think the upshot for this specific finding about the Nyasaland famine is that we were able to document this main effect that prevails, and could not yet or couldn't identify important interaction, which is always the combination of the interactions might be or are likely to be somewhat weak, and we don't have the sample size to actually do we don't have the sample size to identify these interactions. But I think you point out we didn't start off with the hypothesis that this is what we would find, and it turns out that the finding is very, very robust. With regard to cardiovascular health, they're mostly null findings with other dimensions of the health. So there's something really interesting about the cardiovascular system, about these early life influences, kind of Barker's hypothesis, and the cardiovascular system distinct from other dimensions of health. And I think we now have a reasonably good hypothesis about the mechanisms. How that would work is basically priming the cardiovascular system for kind of sustained adversity that may translate this. The one thing that I alluded to this that we could rule out is mortality selection. So if there was strong mortality selection in the 1949 cohort, you would expect this to show up in census age distribution, and we don't find it in the census age distribution. And while individuals were under study in this cohort study, we can measure mortality at adult ages, and they also, if anything, they have lower mortality. So we're reasonably confident, or we're fairly confident to argue that we don't think the finding that we have is driven by mortality selection. It's really, related to these aging processes. And, doing this type of work arguably is the way to find it out, to obtain biological measures of aging, such as epigenetic clocks, and then measure these shocks to which individuals are exposed to. And then, anyway.
But before we're just about to run out of time, so I just want to make sure Begay has an opportunity to ask his question.
Yeah, thank you. I'm going to make it quick. And I think my question is sort of ethics related, and that's because I'm an ethicist, I'm just wondering, engaging with the community, with the people that you conduct this research with, what are some of the activities that you do to ensure that, there is full community engagement, and just to ensure, people are, they feel they are part and parcel of the research project. And given that it's quite a very long duration of cohort that you
And and I think here credit goes to our partners in Malawi. On one hand, I think we've been able to establish an infrastructure in Malawi that makes it possible, that is impartially recruited from the study areas, that has connection to them. We make an effort in disseminating information, and in some ways, with a very broad concept, is treat your study population with a lot of respect in multiple ways, in sharing information, making sure they understand what they're participating in. If issues come up, be sincere about addressing issues, questions that come up. So we've been fortunate of over these years establishing a collaboration with an organization called Invest in Knowledge in Malawi, that we've been built up and kind of the team has, created, and that's credit doesn't go to
it
me,
seems,
it goes
you
to
know,
our Malawi team in doing that and establishing these community relations.
sorry to cut you off. It's after 4. I unfortunately have to run to another
Yeah.
meeting, but I just wanted to say that it seems to me this is a perfect case where you know these people for a long period.
Yeah.
They know you. You're following them over time,
Mhm.
and that this is what you want, is this kind of relationship. If you're doing genetic studies, and there's
Mhm.
certainly, this can be done, as you said, in an ethical manner, and it's a unique opportunity to be able to go back and
Mhm.
recontact people, because often we lose track of where people go. So I just want to say again, thank you so much to you and your team. It's really cool work, and we look forward to further interaction. So thank you so
Fabulous. No,
much.
thank you. Thank you so
you.
much.
Thank-
Thank you,
All right,
everybody.
take care,
Glad
everybody.
for connecting, and we'll follow
All
up
right.
in various ways. Alan, if you're okay.
Sounds good.
Bye-bye.
Okay.